Hello, everyone, and welcome. Our topic for our panel today is analytics in healthcare, opening new frontiers for care. And during our discussion, we're going to explore the role of data and analytics in generating insights that can lead ideally to better health and higher quality healthcare. I'm very pleased to welcome our three panelists for what I know now will be an informative and provocative discussion. First of all, we welcome Dr. Kevin Tabb. He's president and chief executive officer of Beth Israel Lahey Health, where he has led the comprehensive plan to integrate the Beth Israel Deaconess Medical Center and Lahey Health as a result of the merger of those institutions in 2019. Before the merger, he was the chief executive officer of the Beth Israel Deaconess System and Beth Israel Deaconess Medical Center. An MD, Kevin has strong roots in information and analytics. Among his previous positions, he was Chief Quality and Medical Information Officer at Stanford. And before that, he was in the Clinical Data Service Division of GE Healthcare IT. Kevin, welcome. It's great to have you with us.
Thank you. It's great to be here.
And next, we welcome Dr. Jamie Bland. She's the Chief Executive Officer of Sync Health. That's a health information exchange in Nebraska and neighboring states, including Iowa. Sync Health, formerly known as the Nebraska Health Information Exchange, is a nonprofit organization that includes healthcare providers, payers, and the state of Nebraska, as well as Iowa. It shares clinical and administrative information among those entities. The goal is to achieve healthcare transformation while protecting the privacy of health information. Jamie holds both a Doctor of Nursing Practice and an RN degree. And finally, we welcome Alex McLeod, who is head of Global Healthcare Initiatives at InterSystems. She's a 20-year veteran of the company and has worked in various roles in implementation, support, and sales. She works with a wide range of clients in both the government and private sectors and in a number of international markets, including Germany, the United Kingdom, and the United States. Among other achievements, she helped lead development of InterSystems' go-to-market strategy for the HealthShare product portfolio, and that's become her focused area of engagement over the last 15 years. HealthShare, for those who may not know, is a unified, community-wide health record designed to serve as the foundation for coordinated value-based care and population health management. Alex is now working alongside regional and country managers around the world to help lead the growth of HealthShare internationally. And Jamie and Alex, I want to welcome both of you as well.
Thanks, excited to be here.
So to get us started today, I've asked each of our panelists to just take a few minutes to tell us more about their organizations and their roles and give us a flavor of how they are using analytics in their organizations today, or in Alex's case, how she's seeing some of InterSystems' international clients in particular lead the way in making use of data and analytics. After each of them speaks for a few minutes, we'll dive into discussion on some key issues. We're going to talk about how to separate the hype from the actual promise around analytics, how to prioritize the most meaningful analytics rather than niche solutions, and how to embrace data and analytics in the quest for greater health equity, among other topics. We're going to turn first to Kevin Tabb, who will tell us more about how Beth Israel Lahey Health, and in particular, how the organization is making use of data across its various components now to create a true single system of care. Kevin, over to you.
Well, thanks very much, Susan. I appreciate it. It's great to be here. As you mentioned, maybe I'll start just for a moment in terms of my own background, because I have, I guess, a somewhat eclectic background. I'm a physician by training, then spent years in healthcare IT, first on the vendor side in a variety of smaller startups, and then at GE, came back to the provider world, spent years in healthcare IT, and then as a chief medical officer, and then for the last 10 years or so here in Boston in the Beth Israel Lahey Health System. And, I think that one of the things that I've observed again and again over many years, both on the vendor side and now as a provider, is something that you mentioned a minute ago, which is that frequently with healthcare IT, what we see is that the hype, and maybe to the same degree, the promise of healthcare IT far exceeds the reality of what we see. That being said, I think that there are some great examples of where we are really now starting to deliver on our promises to our patients. And the best example that I can give is really what we did, and I think many providers did around the pandemic. And so for us, we're now one of the largest healthcare systems in Massachusetts. We serve over 1.5 million people in the states, about 30% of the state's population. And when we knew that we needed to identify the people that had access to us and needed vaccine, we immediately went in and started to mine our data for how we could find the people that needed it the most as quickly as possible. And so we thought that that would be simple. And it turns out that that was much more difficult than we initially thought. We needed to be nimble in terms of keeping step with the state's prioritization requirements based on need, starting with ages. That's an easy thing, but then it gets complicated from a data perspective as you move through the priority groups. Because we were then asked by the state to prioritize patients with 2 or more medical conditions. And that meant that we had to leverage a set of data in our enterprise data warehouse. And we started by using billing data, but turns out that wasn't the best. It works in some cases, but doesn't work in others. And I'll give you an example there. Obesity. Obesity is not something that's documented as a specific code. And that's a weakness. But then we were able to go in and look further, pull from patients' BMI, add it as a field, and really change our data strategy midstream. None of that's simple. All of that makes a huge difference. And in the end, that's what it's about, because we strongly believe that what's important is to make a difference in people's lives. And we think that leveraging data to do that is really the way that healthcare IT will live up to its promise.
That's great. And did all of that suggest a path forward for the future based on what you learned from that exercise, that very important exercise?
It absolutely did. And it made us think hard about how we get ourselves ready, not just for the next crisis, but for the day-to-day work that we need to do, how we need to make sure that we collect data in a certain way, how we stage things, and that we have the right people, the right teams in place to be able to quickly respond to needs. And that's not specific to the pandemic.
Great, great. Well, a great set of learnings and takeaways. Thank you so much, Kevin. So now, Jamie, let's go to you. Give us again a flavor of how Sync Health is using analytics, and just tell us a little bit more about what Sync Health actually does.
Sure. So Sync Health is the health information exchange and prescription monitoring program for the state of Nebraska. And that is in a Nebraska statute for a number of years. We are in the regulatory code for Iowa, also operating the health information exchange. So between the two public-private partnerships, both having state partners, there's been a robust shift to public health and supporting public health related infrastructure, of course, related to the pandemic, but also looking at how resilient is the data infrastructure in the state and how we can be better prepared for a number of different public health use cases as well as healthcare delivery use cases. So an example of how we have leveraged the statewide infrastructure, both in Nebraska and Iowa, for example, is looking at bed capacity, which is an indicator of healthcare system resiliency. So we have worked with our healthcare data subscribers that connect to us through the InterSystems Health Share product. We have analyzed that information and then pushed it back into a visualization that is provided in real time to the Nebraska market and an asynchronous update that happens in the Iowa market. So through that information, we then begin to build use cases around what does that community resiliency look like for the next pandemic. So we can look at staffing, we can look at the staffed beds versus what it looks like in the community, what are the clinics looking like for utilization, what is skilled nursing facilities looking like, and putting that together in one place really helps policymakers and folks at public health make more informed decisions. So that's one example of how we're leveraging, an ADT to inform for, operational use cases. And then we look at, how we can support clinicians, getting the COVID test results to physicians, using event notification systems to do that, packaging data so that we can look at what the long-term outcomes of, a COVID positive test look like. Those are all things that we're starting to work on. Historically, we've done very similar things with influenza and looking at the impact of, flu in the community broadly, because we are fortunate to have all the hospitals connected in the state and have been able to do a lot of community-based analysis on that as well. And then we can look into value-based care, various use cases, looking at HEDIS measures. We've worked closely with InterSystems for to certify for DAV, so that's a use case for payers, and we really take a more of a utility type of approach to our health information exchange, and that we have to have various use cases across the different stakeholders, which is the beauty of a public-private partnership. So, one of the things that has been a consistent analytical use case is readmission reporting. We provide demographic updates, leveraging MPI related data to enhance both patient matching as well as connect that data across a longitudinal record, from clinical data to pharmacy data. Those are different data standards, and bringing that together in one view. So overall, reducing that burden of aggregating information across systems, leveraging the infrastructure, much like a utility, fulfilling multiple use cases, and facilitating both the advancement of population health and value-based care in the state.
It's really remarkable how you are, in a very exceptional way, bridging the very separate worlds, traditionally very separate worlds of public health and healthcare, in a way that I dare say many states are lacking because of lack of a robust health information exchange infrastructure in much of the country.
Yeah, it's a very unique place. The Health Information Exchange in Nebraska started as a healthcare initiative. Hospitals in the Omaha metro area started the Health Information Exchange, and the state came along as a partner a few years later. So it's always been to drive a use case based upon healthcare delivery. And then with the integration of public health at a later date, we were able to provide valuable use cases to the state, because we already had that infrastructure and understanding of, the burden of multiple registry reportings, and having very engaged partners at a state level, both in Nebraska and Iowa, to understand that and be able to leverage the work that we were doing to connect the community to also fulfill the public health use cases. And that's been very much an accelerator for us across both states, to be able to provide that as a service to healthcare delivery sites, and then be prepared in a pandemic to turn that data into a different use case. We're very fortunate that we have clinicians on staff, we have data engineers and analytics folks that have a lot of experience in healthcare delivery as well.
Great, great. Well, thank you, Jamie, very much for that wonderful description. Alex, let's turn to you now to tell us more about your role within InterSystems, and in particular, what you're seeing abroad as other countries take on the challenge of aggregating data, applying analytics, and really making improvements in population health.
Yeah, and I think Sync Health is a great example in the US of how we're working with clients to aggregate data from different care settings and then surfacing that up for different use cases. And those kind of range from operational analytics to population health to machine learning predictive analytics. My role is really both on the pre-sale side as well as on the actual implementation of those systems internationally, just advising these clients on how best to go about it with the technology, but also kind of learn from best practices we've seen around the world. So as an example today, I would like to talk about the UK a little bit, because the National Health Service there, I think, is a good example of driving care advances from that national level. But also, I think they're doing some very interesting things in terms of the types of data they're collecting. So the NHS has a long-term or 10-year plan that sets out priorities in terms of how to improve healthcare and how to advance population health specifically. And a key part of that is what's called the integrated care systems. So these are partnerships, and there's currently 42 of them in the UK, and they're made up of health systems, mental care, social care delivered by local councils, as well as like charities or voluntary services, because we found that mental well-being really contributes to your physical health as well. So these voluntary services, for example, focus on people not starting to feel isolated during COVID, organizing clubs or afternoon events, providing transport to those events, those kinds of services. And what they've found is, they really think prevention happens in the community and it's not done by the health service itself. So they try to get in early. And one great story from one of these care systems is they try to identify frail elderly people because that population is quite important to manage. If someone falls, they break something, they end up in a hospital, they lose mobility, they lose independence, and often they're dead within 12 months, to be honest. So that's a big population for them to kind of identify. And they found the most significant factor indicating whether someone was frail was whether they had assisted garbage collection or not. And that was more significant than any medical information, which is fascinating, but I guess it makes sense, and it's such a simple factor or metric that you wouldn't even have looked at.
And it clearly was, just to interject, it clearly was a correlate, not causative, right?
Correct. Yes.
Right.
Yeah, it's really correlated. But that helps them just to pinpoint where do these people sit. And then once they've identified that cohort, we support them, assigning them to what they call neighborhood teams, which is made up of primary care, mental care, social services, so that if one of them has an unplanned admission, maybe the GP is in the hospital right then and can help them discharge them to home because they know where they live. So it just drives care delivery from that population level.
And again, an example of finding data you didn't even know existed. Right. Putting it together with other data that you have about the consequences of frailty, falls, etc., and then making the inferences and doing something about it.
Correct.
A great example. And later on, I know you're involved in other systems as well in Germany and the United Arab Emirates. I hope we'll come back and give some examples of what has been possible there as well. So thanks to all three of you for those great opening comments. One example that really has been teed up by what Alex said is the contrast between other countries and the US. I dare say it would be very hard to, first of all, isolate a particular number of integrated care systems, as has been done in the UK, start to mine the data in a way that Alex just described, and use those to advancing population ends on a national basis, obviously region by region or city by city, but obviously collectively to do that nationally. So, Kevin, I know you've got some thoughts about that based on your experience. What does that create inevitably for health systems in the U.S. that cannot be a party to a concerted national effort to take this on?
Yeah, absolutely. Well, so first of all, I trained and practiced in a different country before I came to the U.S. I trained and practiced in Israel, which has a health system that is somewhat similar to a number of countries in Europe, and allows for the kinds of things that Alex was talking about. It's not by chance, for instance, that a lot of the really good data that we're seeing around vaccine efficacy is coming out of Israel. It's because of the interconnectivity and interoperability of the healthcare system there. But I'm frequently asked, what the major difference is between the healthcare systems that we see in Europe and the healthcare system in the United States. And I'd say a couple of things. First of all, there is no single healthcare system in Europe. We see a number of different types of systems, although there are similarities between them. The major difference between any healthcare system that I see in Europe and what I see in the United States is that there is actually no such thing as a cohesive, coherent approach to healthcare at the federal level in the United States. And the absence of that means that because we don't have a concerted approach, particularly to how we deal with data and its use in healthcare, but many things beyond, we're really left dealing with this almost as a cottage industry in silos. And that really creates its own problems. It's also forcing us to come up with our own creative solutions. But the absence of a coordinated approach to this, a singular approach at the federal level, is really very unique to this country.
And an example of the solutions is what you described in your opening comments, basically having to adjudicate between availability of vaccine, which the federal government was involved in, but then the state is in there telling you what groups to prioritize, and then you're stuck, if you will, trying to harness whatever data you have internally to address those concerns.
It is a great example. Unfortunately, that only works for large, sophisticated systems that have those capabilities. And if you're a standalone hospital or a small group practice or whatever it may be, you simply don't have the resources to be able to respond that way. And that presents another challenge, I'd say.
So if you're lucky, you're in a state with a robust health information exchange, like Nebraska's and Iowa's, so that at least you've got some strength in numbers. You've got some data that tells you where you sit relative to your peers, for example. Jamie, what else are you able to do to provide health systems individually with the tools that they need to make sense of population health needs, population health goals, and actually act on them?
So in a state like Nebraska, where we have rural and frontier counties, where we supported the vaccine distribution was in matching the information across different settings, helping the public health department, look at dose 1, dose 2, and those that fell into the gap that didn't have that, and then pushing that information to primary care physicians and providers so that they had access to that information as well. Once you have a mass vaccination for dose 1 and then getting the person back to the same location, especially in a rural setting where it might have been a pop-up vaccine or a drive-through, and then the next time it's in a different location, that turned out to be like very difficult to manage those series of vaccines. And now we're looking at how we do that again for boosters. So that's one way that we supported healthcare systems. The way that we supported public health was to assist in the integration from the distribution from the federal side and look at the supply chain data to needle and arm, right? So once it comes out of the federal allocation system, how do we track it across the very vast geography, and then assist in moving those doses to where they need to be? There's things that we know about utilization of healthcare, who has issues with transportation, just in the data that we're able to support from the looking at various clinics versus ambulatory care centers, urban and rural, and we're able to take that information and produce some counties that would need extra support. So those are types of analytical situations that we're able to look at from an operational perspective and assist the state team in some of that decision making.
Great, thank you. So, Alex, I know earlier this year, ironically enough, many European countries were in awe of how efficiently the U.S. was mustering out COVID vaccines, which is hard to believe, but it was true. They were certainly lagging. England, in particular, I think many people felt that the government had botched some of the early rollout. But beyond that, were there particular strengths of the data collection systems and the integration of the system that gave them somewhat of an advantage in this process?
It's funny. I'm thinking about the advantages now, and Europe, I think, did better pre-vaccinations. So when it was about controlling the pandemic, they were really aggressive in identifying pockets, shutting those areas down, and using that data to pinpoint those hotspots and get on it early. But then somehow, once the vaccination time came around, I think we had problems. And I am European, so I can say this too. We had problems that there's no overarching European, initiative either, where we agreed on what to do. So everyone was each country was waiting for the European Commission to do something, and then we were hedging our bets on how much money to pay, and it just slowed us down. We've since caught up, so that's useful. We've, other than pinpointing hot pockets or hotspots like that, we spent a lot of time on, as Jamie was talking about, helping with the rollout of the vaccinations through our systems. So we have a couple of countries where, through our patient engagement solution, we actually try to get the patients involved through an electronic measure, because some of our customers, even when they just opened up vaccinations to their staff, the phone systems went down within the first day because they would get like 25,000 calls, and they just couldn't deal with that load. So we try to automate a lot of that with them and help them in, automatically figuring out where someone located geographically, which clinic should they go to receive their vaccination. They could then book their appointment, and we would automatically book the second appointment spaced correctly based on the type of vaccine you got. So there's a couple of different areas where we try to help, but we learned a lot, is what I would like to say.
And collectively as a world, we'll do a lot better in the next pandemic, which we will surely live through. So given this situation that Kevin pointed to, where U.S. health systems are kind of on their own when it comes to approaching a lot of these problems of mustering data, conducting analytics, undertaking changes based on those analytics in a kind of a cottage industry fashion, how should they go about prioritizing what data they need, ensuring the quality of those data, and really accomplishing the goals of harnessing the insights gained via analytics to really improve care? Kevin, do you want to start with how you approach that whole set of concerns?
Sure. What we see, I think, is that with all of the disadvantages that I described, there are also some advantages, which is that we see private industry, we see commercial vendors stepping in with some very creative ideas, and we're delighted to try and use some of those things. That being said, I'd caution everybody to be careful, particularly about what I would call niche solutions that I frequently see. So I'm on a weekly basis, I will get pitched an idea or a product by a vendor that on the face of it works well, and yet is extraordinarily frustrating to someone like myself. Because when you look at something that is a niche product, something that solves a very small piece of the problem, while it may solve a small piece of the problem, in many cases, all that it does is shift the problem from one place in our system to another. And for large systems like ours, I would really implore people to take a hard look at what the real needs of the customers are, and what impediments might be to an organization like mine in using insights to improving care. We have limited resources and bandwidth, and I think we are going to focus on a small number of things that make the most difference in improving quality and outcomes of care. And that means, by definition, that there are many, many things that simply we can't afford to adopt.
So what's an example of a niche solution versus a broader solution that, as you said, really gets to essential questions?
Well, I'm gonna stay away from criticizing anybody's individual product, but in terms of the larger solutions that really do help solve problems, I think in general, population health data solutions are things that work well. They embrace the big picture. They take data from disparate sources, hospitals and payers and pharmacies, and then they bring them together to offer a well-rounded, data-driven view of patients. And so, I'll give a couple of examples just to be concrete about it. I think of a patient with multiple comorbidities who receives care from multiple organizations. And then they might go to a specialty diabetes clinic to help manage their diabetes care. Then they go to a cardiologist at an academic medical center. And then they ultimately end up needing a heart transplant at another academic medical center. And then they get their medications from say a national pharmacy chain that's located in their own hometown. It's only something like a population health data platform that is going to bring all of the data together from multiple sources and then help our own case managers identify the kind of proactive solutions that are needed to help patients live a healthier life. And without those broad solutions, providers like ours really only have access to very limited slices of information that don't give the complete picture, and in some cases give a false picture. So those are the kinds of things I think that are particularly helpful.
Great. Alex, do you want to comment on that from your perspective, working with clients?
I think we see some of those same issues internationally. Either solutions are very specialized, like a particular disease, for example, and they follow those types of people, or they're focused, traditionally in Europe or in the UK as well. Hospitals had to submit like anonymized data every time after a patient visited, and that was used for secondary use services. But then the solutions on the analytics side are also focused on acute care data, and they just haven't matured yet in a larger sense to take into account all this other data. And I think Kevin said it well. And I was giving some examples of this earlier, where there's data beyond the hospital system. Primary care alone is very difficult to integrate in certain regions that I work with. But then any specialists they're seeing and any of the social data, so the analytics solutions just have to be mature to work on top of that data. Although I don't want to blame everything on, analytics solutions either, because data is difficult, and even when you can get it from different places, there's different terminology sets and there's no standards, or the standards aren't adopted, and it's very difficult to bring it all together and then use it in a way that's useful.
Or I would just add that, or the standards are very immature, like in the social care space. So we have, broad infrastructure investment into the social care space. And I was talking to my team yesterday that we are in like the CPOE stage in social care, where we are just understanding how to enter the data and then how to get it out.
Say what you mean by CPOE stage in social
like
care.
25 years ago, in the EHR space, where we were beginning to implement electronic systems into hospitals. And I was a very young nurse, and it seems like every day we had a different system to enter data into. And it was, and I really think that's where social care is at this point. And that's, the data standards are immature as well. So when you try to extract that information and match it to an individual and then perform any analytics in that space, the data is immature, right? So the risk and the understanding of that data is going to be immature. And I think that's where, good investment in infrastructure, which we know today will yield better results, will pay off in the future. But to bring that together today and provide deep analytics on that's very difficult, because the infrastructure is not there to do it. And there's no system of care in the social care space, right? Not like, even in for all the flaws in the healthcare system, there's still a system of care that exists. And then when we get into the social care space, the connectedness, there's no PHOs, there's no CINs, there's no ACOs, right, in the social care space. So just the underdevelopment of the connectedness in that space creates issues in trying to aggregate that information and bring, the things we need to focus on to the forefront. It's difficult.
And we're only seeing the beginnings of
Right.
some efforts to coordinate all of that. In North Carolina, there's NC Care 360, which at least is bringing together the names of all the community-based organizations and others that are organizing and orchestrating social services. But we're a long way from getting all of that information of what they actually do for patients integrated fully into EHRs, et cetera. So,
And then attributing that to outcomes. I mean, that's
right.
we have a lot of anecdotal information at this point.
Yep. So I guess that gets to another set of questions, which is if you're a health system and you're thinking about executing on a data and analytics strategy, should you think about this as being a technology problem, a standards problem, a people problem, or all of the above? Jamie, why don't you start with that?
I think I think technology has evolved. We have a lot of capabilities in technology. The barriers that we see are people and standards. So, you focus gold in, gold out, right? So the data work that happens to understand workflow and extract that information and create insights into care outcomes that starts at the very beginning of data entry and the codification through standards. That's beginning to catch up now to the capabilities of technology, and then it's change for people, and that change is hard, and we are all really fatigued at this point in time from various events like the pandemic, or just being short staffed, nursing turnover, that kind of thing. It's very stressful at this point, so it's a huge problem in how we address the future.
Alex, what would you say among those choices? What's the greatest impediment, if you will, to executing a good data and analytics strategy?
I would say, and you mentioned a lot of the barriers, and I think it's all of the above to some extent. On the people side, I think there's a lot of training that needs to be happening, and just around awareness of what type of data is out there and what that data looks like. I think, as Jamie said, the technology is good, but the data is, the data quality, the data equity, there's a lot of issues we have that we need to overcome on that side, and technology can certainly help, but people need to be educated as well, including myself.
Well, that's right. It's not a stagnant world. It's constantly in flux. Kevin, from your perspective as a system CEO, how do you prioritize these issues, these barriers?
Well, so I actually don't think that it is all of the above, or certainly not all of the above equally. I don't think that there is, for the most part, a technology problem. We have plenty of technology solutions. We have plenty of features and functions. The problem is really a people problem, a culture problem. And, we've run into this of late, particularly as we are trying hard to deal with issues of equity in healthcare. And as we put in place a host of different solutions that we know we need to put in place to deal with these issues, what we find is that we're struggling with some very simple things, like consistently recording patient diversity demographics, including gender and race and ethnicity and language. And one might think that's a simple thing. One might say, just make it a required field in an EHR and then you'll have it. Of course, it's not so simple. And of course, there are a lot of different ways to record that thing and a lot of different ways to get around it. And so, we've launched a whole initiative as a piece of our larger system-wide efforts around analyzing health disparities just to make sure that we capture data consistently across a patient population of more than 1 million people, and to make sure that we then understand health disparities and the root causes. And it's those kinds of things that are going to be really important. It's not the technology. The technology exists, but we've got to get really at the heart of what the problem is.
Well, you've also steered us right smack into the next area we hope to discuss today, which is equity. Obviously, that having risen as a primary of focus for health systems individually and collectively and nationally. And so as we think about how health systems can use data analytics to advance health equity, you've just teed up one essential issue, which is you've got to start capturing the data in the right way to understand what is actually going on now before you can understand where the disparities are falling and how to deal with them. So, Kevin, having teed up that question, Alex, first of all, let me ask you, how are European nations dealing with those issues around equity and diversity in the context of data and analytics?
So it is very difficult, and let me come to it from two angles. One is, one of my personal passions, and certainly something InterSystems has worked on a lot over the past couple of years, is machine learning, and that suffers from, data inequity a lot. You have years of disparities sitting in that data, and the way machine learning works is it looks at your past and it predicts the future based on that. Now, if your past is all biased, the model is tilted, and there's a downside for the minority groups that are not represented accurately in that data. So we've seen cases, for example, where we saw a model being built of who needs extra attention, and white people were 3 times more likely to get extra attention because the data that was used to kind of proxy indicate that was projected costs. Yeah. And traditionally, white people have received better care. So, that's the data it learned from. So it's a huge issue. And I think awareness on the people side is the only way out of that until we get better at data collection, like Kevin said, because you just have to be very aware of your metrics and what you're looking at and what you're training your models on. If I go back to the UK for a second, and they're obviously pretty far along the path of collecting other types of data. They, as an example, have the biggest Nepalese population outside of Nepal, and they know, based on the social determinants of health and the demographics, where those people sit, right? And then they can change their engagement strategies to deliver better care to those sub-cohorts. So they, for example, engage faith communities, again, things you would have never thought of traditionally, but it helps culturally, provide local language materials, those sorts of efforts. But you need to get there with the data first.
Well, we can just imagine if that kind of capability had been in place in the US to understand, for example, populations and vaccine hesitancy. Right. Amazing. Jamie, what about from your perspective? How are these equity issues playing out with respect to the data that components of the HIE are collecting or not collecting, and how you all are able to help them make use of that information?
Yeah, so I think we play a role in this is to understand where populations of risk are congregating, working, living, worshiping, and using that information to then inform populations at risk. We were able to take some models that we had worked on and identify populations at risk, and pre not pre-pandemic, but in the early days of the pandemic. And our data quickly showed that those that worked in factory settings or around meatpacking plants were going to be at higher risk because they're at higher risk for flu. They're at higher risk for disease that impacts hospital bed utilization. So there's various things that we can look at in a well-crafted ADT that are able to generate a lot of information from a public health perspective in identifying vulnerable populations. And then we're able to couple that with census information or socioeconomic data that we're able to use on a geocode level to then bring that into for some prospective analysis on populations that may be at risk for certain factors. So like exposure or eventually ending up in an inpatient bed. So that's how we were able to leverage the data in some of the early days of the pandemic.
Another use case that emerged from the pandemic that obviously will be applicable in other contexts as well. So thank you for that example. Well, we have covered a lot of ground in our conversation today, starting with the terrific examples that all of you mentioned about how systems, whether it's Beth Israel Leahy, whether it's what is happening in the UK, actually can take data and put it to use, developing the analytics necessary to figure out how to distribute vaccines, who to get vaccinated. The example that you told us about, Alex, of understanding that there's a correlation between people not getting their garbage picked up and becoming frail elders. Wonderful examples of the uses of data and analytics. We've also talked about some of the barriers and the obstacles and heard some varying perspectives from all of you about the degree to which it's a people problem, it's a workflow issue, but I guess some consensus that at least it's not a technology issue per se. We've also talked, as we have just now, about equity and uses of data and analytics and equity, and Alex raising the good cautionary concern that we've got to make sure that we understand what the data is that we're using in the context of applications like machine learning to make sure that we don't compound the biases of the existing system by not being wise to the biases already inherent in that data. So lots of great examples of that all of you have presented for us about how to use data well and analytics well and how not to, and how, as Kevin said, get a handle on the hype and understand the real import of the kinds of solutions that can truly make a difference in advancing health. With that, we've just got a minute or so left, so I'd like to take each of you to just briefly give our audience a next step. What's the single most important thing that they need to keep in mind as they are confronting the issues of data and analytics in their own organization? So maybe 30 seconds from each of you. Kevin, let me start with you.
Yeah, I'd go back to what I said earlier, which is I'd implore those of you who are offering up solutions to put yourselves in our shoes. And I would implore those of you who are providers to put yourselves in the shoes of our patients. And really to think about, given how many different things we have on our plates, what are those solutions? What are those things that we can do that don't simply shuffle around the problem from one place to another, but will really and truly make a difference in the lives of our patients and the communities that they live in?
Great, thank you. Jamie, your quick take on what people need to keep foremost in mind.
I think there's an investment in infrastructure that needs to happen in states around good plumbing for data, and we'll be able to yield very good results from that if that's the investment that's made.
Great. And Alex will give you the last word.
Right. I think we've made great advancements already over the last couple of decades in individual care at the EMR level, but we're sitting on a goldmine of data we could use for population health and kind of driving care differently from that level. And I'd like to close actually with a quote. I talked to a cardiologist a couple of weeks ago, and I really liked what he said, because he said, I'm stepping away from my current role, sitting in front of a patient, to take a look at the population and really help that patient from that angle. And I thought that was inspirational, and I'm optimistic and hopeful. You know, there's some issues still, but we can work towards making good use of that data.
And do that at every level, even as we've talked about in our very difficult operating environment here in the United States. So thanks to all three of you, Kevin Tabb, Jamie Bland, and Alex McLeod, for a great discussion. And thanks to our audience for listening in on this as well. Have a great day, everybody, and thanks again.
Thank you.
Thank you.